I'm Shannon Acker. I'm a pediatric surgeon at Children's Hospital Colorado, and I'm going to be speaking about a study that we led through the Western Pediatric Surgery Research Consortium. So for a little bit of background, adhesive small bowel obstruction, or ASBO, is the most common cause of morbidity following an abdominal operation. Between 1 and 12% of children will develop a bowel obstruction following a laparotomy. A bowel obstruction can develop at any time after an abdominal operation, with the highest risk during the first year after surgery. The current approach to management of pediatric bowel obstruction involves a period of bowel rest, decompression via nasogastric tube, and observation to allow the obstruction to resolve on its own. The published literature reports that between 16 and 65% of children with bowel obstructions will resolve without surgery. When employing a non-operative management strategy for pediatric bowel obstructions, surgeons must balance the risks and benefits of early surgery versus observation. The benefit of a non-operative approach includes avoiding unnecessary surgery. However, if a bowel obstruction is not going to resolve on its own and surgery is delayed, the patient can develop intestinal ischemia, which requires small bowel resection. In the adult population, surgeons frequently utilize contrast protocols to help determine who is likely to resolve their bowel obstruction without surgery and who will require an operation. A contrast protocol involves administration of a radio-opaque water-soluble contrast agent enterally at the time of diagnosis of the bowel obstruction. This is followed by serial abdominal x-rays. If the contrast makes it to the colon within 24 hours, this is evidence that the bowel obstruction is likely to resolve without surgery. In the adult population, the benefits of contrast protocols include earlier resolution of the bowel obstruction, shorter hospital length of stay among patients who do not require surgery, and a decrease in the number of patients requiring an operation. Contrast protocols are also used to inform management of children with bowel obstructions. However, there are concerns regarding the risk of the high osmolar contrast agents, which can cause fluid and electrolyte disturbances in small children. Additionally, there are very limited data demonstrating the benefits of contrast protocols in children. However, the data do suggest this approach is likely safe. And finally, prior to initiation of our study, we conducted a survey of practicing pediatric surgeons and found that 2/3 of practicing surgeons use contrast protocols in the management of children with bowel obstructions, despite the limited data available. With this in mind, we aim to determine if an enteral contrast protocol for pediatric SBO decreased the need for operative intervention compared to non-operative management alone. To address our aim, we conducted a prospective observational study across 9 institutions that make up the Western Pediatric Surgery Research Consortium. We enrolled children aged 1 to 20 years diagnosed with an adhesive small bowel obstruction by an attending pediatric surgeon who underwent a trial of non-operative management. The use of a contrast protocol was at the discretion of the attending surgeon. Exclusion criteria were the presence of peritonitis, suspicion of incarcerated or internal hernia, active intra-abdominal malignancy, inflammatory bowel disease, or less than 4 weeks since the most recent abdominal operation. Comparisons were planned between those children who received contrast and those who did not. The primary outcome was need for operation. We initially powered the study to detect a 15% difference in operative rate based on the adult literature, and we aimed to enroll 314 children. However, the study was stopped early as all centers began to use contrast protocols for nearly all children who presented with ASBO. We enrolled 136 patients, 62% of whom received enteral contrast. The rate of contrast use varied across the 9 sites and ranged from 7% of patients at one site to up to 100% of patients at other sites. 71% of children were male, and the median age was 12 years. There was no difference between the contrast and no contrast groups related to age, sex, or number of prior laparotomies. More than half of children had undergone 2 or more prior laparotomies. There were no adverse events related to contrast administration, such as allergic reactions or acute kidney injury. When comparing the contrast and no contrast groups, there was no difference in median time to trial of enteral feeds after admission. Median time to feeds was 60 hours in the no contrast group and 40 hours in the contrast group. There was no difference in the number of children who required surgery, 35% in the no contrast group compared to 37% in the contrast group. And there was no statistically significant difference in readmission rate, which was 6% in the no contrast group and 17% in the contrast group. Looking just at those children who were successfully managed without surgery, the hospital length of stay and readmission rates also did not differ between the contrast and no contrast groups. And finally, when looking at those children who did require operative lysis of adhesions, which included 36% of all patients, there was no difference between the contrast and no contrast groups regarding time from admission to the operating room. There was no difference in the number of children who were managed with laparoscopy compared to laparotomy, and there was no difference in the rate of small bowel resection and no difference in the total operative time between the 2 groups. Based on these data, we concluded that enteral contrast protocols are safe in the management of children with adhesive small bowel obstructions. The use of contrast protocols does not shorten the hospital length of stay or decrease the need for surgery in children. And finally, the use of contrast protocols can be considered in the management of ASBO in children. Thank you for listening, and please feel free to reach out to me with any questions or for additional information.